Hello, Dan. Welcome, and thanks for joining me in this presentation on mastering ultrasound guided procedures. It's great to have you.
Thanks, Paul. It's a pleasure to be doing this third Sorcerer and the Apprentice sequel.
Yes, it's our third one, and it makes me pause and reflect. And I'm grateful that we're involved in teaching residents and fellows.
Absolutely. So today we're going to cover a range of topics and try to give a little bit of the tips and the pearls on how to perform ultrasound guided procedures. We're going to cover the ergonomics, settings for the machine and selection of the probes, how to hold the transducer and hold the needle when you're performing a biopsy, how to best image the target, eliminating variables in ultrasound guided needle placement to optimize your procedure, and also the use of color Doppler flow and a little bit of contrast enhanced ultrasound. So first things first, obviously when we're doing an ultrasound guided procedure, any procedure, you want to make sure the patient is comfortable in a stable position. Are the arms out of the way? Are the clothings and the sheets out of the target, out of your needle entry site? You want to make sure you prep a large area so that you're able to visualize where you're going. The area is large enough so that the towels and the drapes are not going to be in the way. Then you should ask yourself, are you comfortable? Make sure you have the bed height where the procedure is being done optimized for your height so that you can work without bending too much or without stretching yourself too much. So this is an example of a procedure being done where Paul here is definitely not very comfortable. You can see how he's bending down to be able to access the area where he's going to be performing this biopsy. And in the other example, the patient is far away from him. So he's actually stretching over the bed to get an optimal position, which is not ideal. So good ergonomics is very important. You see how Paul's position is a lot more natural now. He's standing straight. He's very close to the field. His hands are actually at the elbow level. The monitor is very well positioned. You see how he's taking advantage of the arm and he's stretching that arm and the monitor so that he can actually maintain in this position, look at the patient and the monitor at the same time. And also his hands are not crossed.
Familiarize yourself with the ultrasound machine settings before you begin doing ultrasound guided procedures. And of course, every vendor is a little bit different. Most machines have presets for particular body regions, so choose the appropriate one that gets you kind of close in terms of settings. You have to be able to adjust the gain overall and also time gain compensation to adjust the gain based on the depth of the target. And so we often increase the gain proportionally more for deeper structures. Select the focal zone. Usually we want a focal zone that's at or slightly deep to the target. Sometimes we use multiple focal zones. And don't forget to zoom or magnify the image appropriately. And then as you do the procedure, annotate your images as appropriate. For example, the body part that you're targeting. Don't forget to measure things that need to be measured, whether it's the target or the depth from the skin incision to the target. You have to know how to freeze and unfreeze the ultrasound image. And then, of course, very important to save images and video clips from the procedure for documentation.
One thing I would like to add, Paul, is that don't be shy in trying different presets. Although some procedures are labeled abdomen, for example, there are several machines that have an abdomen 2 option, and there's sometimes a preset, even if it's not labeled in the correct body part, may work better for your target. The other point I would like to make is about the focal zones or focal points. You can actually increase the number of focal points or decrease the number of focal points. If you have too many focal points in the image, that comes with an expense of decreasing your frame rate. So I typically will leave only 1 or 2 focal points when I'm doing these procedures.
That's exactly right. And of course, there are many other settings and adjustments that you can make on the machine, but this is sort of the basics. Here's an example of the gain being set too high, so the image looks washed out.
So this is an image demonstrating all the different transducers that may be available for you when you're doing a procedure. On the top left, we see the hockey stick is one of my favorite transducers for superficial biopsies, especially superficial lymph nodes. The sector probe can be very helpful for performing intercostal approaches and also gives you a lot of penetration. So it's very good for liver dome lesions, for example. The linear array is very good for giving you spatial resolution, but as you can see, especially in comparison with the hockey stick, it has a very wide footprint, and you may have to have your needle be placed very shallow to be able to see it along with the target. Endocavitary transducers and curved array transducers are not depicted in this image, but obviously the curved transducer is very often used when we're doing ultrasound guided biopsies. Important to remember that even when you're using a linear array, a lot of machines are able to give you a convex image so that you can increase the field of view when you're performing these procedures. Like in this example here on the left image, we didn't modify the settings of the machine. On the right-hand side, there's a virtual convex button that you can press so that you can actually expand your field of view and see more of the tissue surrounding your target. So this is an example of a hockey stick probe for biopsying smaller superficial parts. You can see how your target and your needle is very, very close by, and that's a major advantage over the typical 15 megahertz linear array transducer. Next step is preparing your probe, making sure the probe is clean. You want to place a layer of gel without any bubbles on the probe head and try to minimize the amount of bubbles because, as you know, the bubbles are going to obscure your image. Once you play the probe cover, make sure there are no wrinkles. Those wrinkles are going to deteriorate your image. And I try to apply a lot of tension in the probe cover so that you have absolutely no wrinkles or bubbles when you're imaging your target. And then once you have everything ready, make sure you're only holding your probe when you're actually absolutely using it. So for example, when you're applying your local anesthetic, it's helpful to have both hands available. When you're making an incision, when you're inserting or removing your coaxial needles, you don't have to necessarily be occupying one of your hands holding the transducer.
Yes, especially for the superficial cutaneous local, it's more convenient to put the probe down. And then when you do your deep local, you can pick up the transducer. When you make an incision, being able to stabilize the skin with one hand and then make the incision with the other works great. So that's a good point, Dan. So when it comes to holding the transducer, there's a tendency for the novice to kind of hold the transducer by the handle so that their hand is kind of floating in midair. But that's a problem because then you're not stable, your hand position is drifting. And so it's better if you hold the transducer near the head of the probe so that your hand is resting on the patient's body. That has several advantages. One is that it reduces tension in your arm when you're not trying to stabilize the probe in midair and when you're resting your arm on the patient, it just reduces the muscle tension in your arm, which will make you more comfortable. And it connects you to the patient, and that gives you a stable frame of reference. So, for example, as you're holding the probe and looking at the monitor, when you see the lesion, if your hand is resting on the patient, then you have a very stable view of the target, and it doesn't tend to change as you manipulate the needle. And it allows you to look at the monitor, look at your hands, and even when you're looking away, things don't change. So it's very important that your hand is kind of connected to the patient as you hold the probe. The other thing I would add is that it's very helpful to be ambidextrous when you do ultrasound guided procedures. It's almost essential because depending on the body parts you're working on and the orientation of the patient and things like that, it is sometimes advantageous to use the left hand to insert the needle while you hold the probe with your right hand, or you hold the probe with your left hand and insert the needle with your right hand. Very often, one of these two different approaches is going to be much more comfortable and ergonomically feasible. And so sometimes the novice ultrasound interventionalist is averse to using, for example, their left hand if they're right-handed to insert the needle. But the sooner you kind of get past that and learn to be comfortable using either hand, the better. So for example, here you can see on the left, kind of an awkward position where you're reaching around the probe so that you can still use your right hand to insert the needle. But not only does it lead to tension, but it also reduces your 3D sense of navigation when you have your hands crossed like that. So on the right hand image, on the other hand, when you use your left hand to advance the needle in this case, it's a much more natural position. As you get comfortable using both hands, this will be just as effective for you as using your right hand.
So, Paul, another skill I think that should not be underestimated is how to hold the needle. I think it's very important to avoid holding the needle in the shaft like we hold the pencil, for example, because holding the needle on the shaft requires you to squeeze the needle too hard to keep it stable, and that causes a lot of tension in your arm. It decreases how much tactile feedback you get from the needle tip. So as you advance through the different facial planes and capsules, it's harder to perceive those differences in resistance. And it also reduces your 3D spatial orientation. So whenever you're holding your needle, try to hold it by the hub, or at the very least, place one finger or your thumb on the hub so that you can actually perceive those differences.
Yes, and just another example on the tactile feedback is that when you come to a fascial plane or a capsule, it's a lot easier to just pop it in if you have a finger on or a thumb on the hub, or if you're holding the hub. It's a little bit harder to do that when you're holding the needle shaft. And it's interesting how instinctively trainees always want to hold the needle by the shaft. This is a point that really requires emphasis.
The next step, obviously, is appropriately imaging the target. You really want to set yourself up for success. So you want to make sure you find the best consistent sonographic window possible. You want to try to find a window that allows you to see the target at all times. It's not always possible. Sometimes there's a lot of respiratory motion that may take the target out of the way. At the very least, you want to be able to see the target very well during expiration and consistently see the target at all times. That's the only way you're going to be able to do this successfully. You also want to be able to translate what you're seeing on the ultrasound monitor to what you're actually seeing when you look at your hands and your transducer and the needle. So this is an example. As you know, when you're looking at the images, the probe face is always at 12 o'clock at the top of the image. Your transducer is depicted on the image. In this example, the transducer is actually at the same orientation as the image on the screen. On the red line, we can see the needle and where I expect the needle to be and the angle of the needle in relationship to the transducer. Horizontal being 90 degrees with the probe, 0 degrees being completely parallel to the probe. Always compare that needle angle on the ultrasound image with the needle angle on the probe. This is straightforward when the transducer is facing down and at 12 o'clock, just like we see on the monitors. So depending on the orientation and the direction that the transducer is playing on the patient, the direction of the needle can be completely different, despite the fact that the image you're seeing on the monitor is exactly the same. So in this example here, in all these positionings of the transducer, the image on the screen is going to be exactly the same. But as you can see here, the right lateral approach, the anterior approach, and the left lateral approach are actually giving us a direction of the needle that is completely different.
Exactly. That's a very helpful point to make, Dan. This is one of the things that is the hardest for trainees to learn is how to translate what they see on the monitor to what's actually happening inside the patient and to correlate their hand position with what they see on the monitor. So this is a very useful point to make.
And you also should be able to recognize when a parallel approach is needed. We tend to always use a 45-degree approach from the needle to the transducer. And sometimes it can be helpful to use actually a parallel approach in which the needle is completely parallel to the probe, like in the example that we're seeing here.
Yeah, that's a great point. This is one of the things, again, that trainees have trouble with. They are reluctant to kind of bring the needle totally parallel to the probe. Now, it may be that you can angle the transducer a little bit and then create an angle for your needle relative to the probe. But there's some situations where you don't have that luxury and you really do have to take a parallel 0 degree approach. So let me take you through eliminating variables in targeting using ultrasound guidance. I love to think of the approach to ultrasound guided procedures as eliminating variables. Here's a list of 5 variables that are really kind of the core of how to get you from the skin to the target consistently. One of them is that the target should be visible on your ultrasound image. That tells you that the image is in plane with the ultrasound probe. That may be that you have continuous, constant visibility of the lesion, or perhaps the lesion just comes into view in expiration. But either way, it's nice if you can hold a stable hand position so the probe is not moving. The second variable is lining up the left or right end of the ultrasound probe on the skin incision so that the needle entry point is on one end of the ultrasound probe that sort of represents one side of the ultrasound image plane. And the third variable is keeping the needle in plane with the ultrasound beam. The fourth variable is adjusting the angle of the needle to the probe. And the fifth is knowing your depth to the target and the length of your needle. If you take these five variables into account, the idea is that even if you don't see the needle, if you have accounted for these five variables, you should be able to get very close to the lesion regardless. So it gets you to the ballpark. Let's go through these. We mentioned keeping the target in view on the ultrasound image. The second one is, again, lining up the needle on the end of the probe. The image on your left shows a needle that's being inserted at the end of an ultrasound probe so that it will course along the ultrasound beam. Schematically on the right side, you can see we have a needle entry point at the end of the probe and a target lesion that is in plane with the probe image. And if this is a sector or a curved array, then the target lesion is in the fan view of the ultrasound beam. And that means that the needle will be continuously visible as you advance it from the skin to the target. That's why we want to have it lined up. Now, what sometimes happens is that after you've done your preliminary imaging, you've marked the skin, and now you've prepped and draped the patient, and you re-image, and all of a sudden, the lesion is no longer in plane as you thought when you put the probe in line with the needle entry point. What this means is that you now have a needle course that's going out of plane. There are a couple of things. One of the common causes of this is that when we sedate patients, they have a reduced tidal volume. And so the diaphragm is kind of positioned higher, the liver moves up. And so the target is literally more cephalad than it was when you were doing your planning image. One way to avoid this problem is to do your planning in an expiratory phase of imaging so that you kind of anticipate what might happen during sedation. But there are a variety of reasons why this can happen. And if you find that the lesion is no longer in the original imaging plane, you kind of have three options. One is to create a new entry point. So pick a new point to insert your needle. The second option is if you use the planned needle entry point, tilt the probe so that you can see the lesion and still be lined up on the incision. And the third is to rotate the probe around the incision site. If you look at this image, for example, we originally, let's say, had the probe kind of more vertical. We saw the lesion and we were lined up on the needle entry point, but now the target is a little bit out of plane. So we're going to tilt the probe so that we see the target lesion, but we're still lined up on the needle entry point, and we've brought the needle in plane with the probe. So that's one solution to addressing this problem of a lesion that seems to be now out of the original imaging plane. So many times trainees feel that they can just slide the ultrasound probe and sort of translate the probe off of the needle entry point until they see the target. But the problem with this is that you're no longer lined up on your incision. So even though you see your target lesion, the probe is not lined up on the needle entry point, and the needle will be traveling out of plane, which means you won't see the entire course of the needle as you advance it from skin to target. The solution to this is to think of your ultrasound probe as the arm of a clock. The center of the clock is the needle entry point. So now if you rotate the probe like the arm of a clock around the needle entry point, you can maintain alignment with the needle entry site and still have the lesion in the ultrasound plane of imaging. So the next variable is keeping the needle in plane with the ultrasound beam. This is one of the hardest things, I think, for novices to get used to. And that's because even if we're holding the ultrasound transducer in a stable position, our hand is resting on the patient, our other hand is holding the needle, and that hand is necessarily floating in midair, so to speak. It is very common that the trainee kind of has that needle drifting in and out of the ultrasound plane. With experience, you will tend to do that less, but you do have to visually check every now and then to make sure you're in plane with the transducer. That's an important variable and allows you to keep the needle in the ultrasound imaging plane the whole time.
Another point, Paul, that I'd like to make here is that the fact that you're visualizing part of the needle does not mean that you're seeing the entire needle, or that does not mean that the needle is in plane.
Yeah, that's crucial. And we'll talk a little bit more about visualizing the needle tip because that's kind of how you're also particularly confident that you're seeing the entire needle. So the fourth variable is adjusting the angle of the needle to the ultrasound probe. And so as Dan kind of showed you, you learn to be able to translate what you see on the ultrasound monitor to what you see at your hands. Crucial is being able to adjust the angle of the needle to the probe to match what you see on the screen. So if what you see on the screen suggests that you need a 30-degree angle to the probe, you want to know how to do that with your hands, to create a 30-degree angle. The final variable is knowing the depth to your target, which you can measure before you even start inserting the needle. And also, very important, know the length of your needle. I can't tell you how often I've watched trainees because I'm kind of looking over their shoulder. I sometimes don't realize how far they've inserted the needle, and they don't have an appreciation for how far they've inserted the needle. If you measure the distance from the skin to the target, you know how long your needle is, it will kind of force you to think about these numbers. So, for example, let's say you have a 15 centimeter Chiba needle and you've measured your target as being 7 centimeters from the skin to the target. Well, once you've got half the needle inserted, you know that you should be right about at the target. If you've got a lot more needle exposed above the skin, then you know that you're well short of the target. On the other hand, if your needle is just two centimeters is left outside the skin, you know you've gone way too far. This is another thing that takes experience to sort of be able to monitor this intuitively. But until you get to that point, and even after, it's very useful to do measurements and remain aware of how much needle you've inserted, how much is still outside the patient, and how that correlates with what you're seeing on the monitor. And so, for example, when you look at the ultrasound monitor, do pay attention to the ruler on the side of the image. It gives you centimeter increments, and it's a quick check on how deep your needle is or how deep your target is, and then just correlate that with what you see when you look at the needle on the patient. This brings us to the issue of biopsy guides. These are attachments for your ultrasound probe. And if you think about it, what a biopsy guide is a device to eliminate these variables in targeting. And what variables does it eliminate? Number one, it ensures that the needle is going to enter at the end of the probe, and it's going to be oriented in plane with the ultrasound beam. So those are two variables. It's going to place the needle along the end of the probe. That's variable one. It's going to keep the needle in plane with the ultrasound beam. And thirdly, it fixes the angle to the transducer. So that leaves you with the depth. And then the other variable is, of course, keeping the lesion visible on the ultrasound monitor. So the ultrasound guide attachment essentially takes care of three of these variables for you. It's useful for people that don't do these biopsy procedures very often. It's useful for the novice. Occasionally, experienced users will use it because it will help with maybe very difficult deep targets getting started. And then you can pop it off once you get close to the target to make fine adjustments if necessary. But most experienced users find that using the ultrasound guides is more trouble than it's worth, but it does have its role.
So there are many tips that we can use to improve needle visualization. One of the things you can do is use an echogenic tip needle, but these needles tend to be more expensive, so we tend not to use them. One of my favorite tools is actually changing your angle transducer beam to becoming a little bit more perpendicular to the needle. When the needle is at 90 degrees with the transducer head, usually there's more reflectivity so that the needle is a lot more visible. All the sound waves are actually going back to the transducer. And some people refer to this maneuver as the heel-toe maneuver. Another tip is maybe potentially jiggling or torquing the needle very slightly without modifying the needle length or the needle depth to identify the needle tip. You want to minimize transducer motion while looking for the needle, very subtle motions without changing the depth again. You don't want to be changing the depth without visualizing the tip. You want to confirm that your transducer is lined up with the needle entry site and that the needle is in plane, as Paul was mentioning earlier. You also want to confirm how much needle has been inserted. And sometimes, since we can modify the depth and the magnification of the image on the screen, you want to make sure you're also paying attention to the ruler to make sure how much needle needs to be introduced and how much needle has been introduced. You don't want to press too hard or too little with the transducer. You want to optimize the image and you want to optimize visualization of both the lesion and the needle. And also you can inject ultrasound contrast into the needle shaft. Some people have referred to this as the lightsaber technique.
Yeah, and similarly, sometimes just moving the stylet back and forth in the needle will help you visualize it.
And also, obviously, the larger the needle, more easily visualized it will be. So some people will use a 25 gauge needle just for skin anesthesia. Once you've applied the anesthesia to the needle, you can use a larger 22 gauge for deeper anesthesia, so you can visualize that needle better. Scanning between the ribs, you want to make sure you keep the probe parallel to the ribs in most cases. And if you do need to angle your probe up, you want to make sure you're sliding your transducer down slightly on the rib below and angling up. You want to keep that very narrow acoustic window open at all times. You don't want to hide your transducer behind the rib. Some pitfalls that may obscure your view is certainly injecting air bubbles with the local anesthetic. I usually avoid injecting that last drop or that last 1 ml of local anesthetic because I want to avoid injecting air when I'm giving the local anesthetic. You want to avoid parking an open needle in the peritoneal space and avoid allowing the air to enter the peritoneal space because air is the enemy of ultrasound. As you know, if you have air, especially along the surface of the liver, that can be a problem when you're visualizing your target. And then when you're reinserting the stylet back and forth and you're doing multiple cores through an introducer needle, you want to try to avoid pushing too much air into the target tissues or the adjacent tissues and avoid obscuring the anatomy.
Yeah, Dan, I'll sometimes preferably leave the needle open and not reinsert the stylet between core biopsy samples precisely just to allow blood to back up a little bit in the needle, as long as it's not coming out too much. Or if I do put the stylet in, just put it in a few centimeters so I don't empty the shaft. And then when I take out the stylet, there's a column of air that I can then push in with the core biopsy needle. If you're slow, if you leave it open and you're slow, the blood can clot in the needle. So just be aware of that. So you want to, with experience, move quickly.
And then using color flow Doppler is very important for real-time visualization of blood vessels. That's one of the major advantages of using ultrasound for guidance. You want to remember that when you're visualizing the vascular structures, every portal vein is always accompanied by a hepatic artery and a bile duct, and obviously we want to avoid those structures. And obviously you can use contrast-enhanced ultrasound. It's a little bit out of the scope of this talk, but certainly contrast-enhanced ultrasound can help characterize lesions. It helps, especially with visualization of isoechoic lesions. And also if you're doing biopsy of heterogeneous masses, using contrast-enhanced ultrasound can actually highlight what's viable tissue versus what's necrotic tissue and fluid so that you don't get a non-diagnostic specimen. We covered a lot of ground. We talked about ergonomics. We talked about ultrasound machine settings, the different probes, how to hold the transducer, how to hold the needle, how to best optimize imaging the target, eliminating the many variables in ultrasound-guided needle placement to make your procedure successful, and also about the use of color flow Doppler and contrast-enhanced ultrasound. And these are all very important concepts that we tend to emphasize when we welcome new classes of trainees. We have been doing this for the past 5 years, a simulation session on ultrasound-guided procedures. And now we've been doing this every year with fellows and residents. We emphasize everything that we talked today using phantoms, and that can be very helpful so that the patients are not being used for this initial part of training, but also the trainees feel a lot more comfortable practicing these skills in phantoms before they actually do this in a real patient.
Dan, that's fantastic. the training with phantoms and in our simulation center is just a great concept. I hope everybody is either doing it or thinking about doing it. So thank you everyone for your attention. Dan and I would both be happy to hear from you. If you have any comments or questions, we're always happy to be reached. Thank you.
Thank you, Paul. Thanks, everyone.